So next up, we're going to talk about our therapeutic drug monitoring. I mentioned this is where we actually take drug levels from the blood and try to determine are the levels too high, too low, just right, in order to treat various number of diseases. Right? These concepts here. So remember, when we're talking about these drug levels, remember peaks and troughs. Right? Peaks is what essentially? They're Cmax, so the maximum amount of concentration we're going to get out of a single dose giving that. So again, if you were to look here on this graph, you're going to see time on the x-axis, drug concentration or level in the blood. On the y-axis, you're going to see here the peak is going to be that max amount, Cmax, we're going to be able to get within the body. The trough is going to be what? The lowest concentration before the next dose, essentially, right? So again, with something given, like say every 12 hours, if I wanted to see what the trough concentration was, when would I check that level? Basically right before the nurse gives that next dose, right? That tells me exactly what the lowest level the patient's going to achieve before they receive their next dose, right? That can be very important. So for instance, if you're looking at this graph right here, so imagine I'm giving a drug, say every 12 hours or so. It looks like it's every 12. You're not. You're giving it 9 and 7, it looks like. So imagine giving it, and so I'm seeing my peaks and troughs. And again, when you achieve this very kind of steady sort of concentration here, what do you call that? A state of steady concentrations. Steady state concentration, yes, good job. Right, so again, when you're giving doses intermittently like that, you're going to have some vacillation between the peaks and the troughs, but the average concentration should stay relatively the same. Anyone remember how long it takes to get to that point? 4 to 5 half-lives or so. So again, some drugs you can get to that very quickly. Some drugs are going to take forever unless I give what to bypass that. We talked about loading doses. Remember, that's one way we can actually get to steady state concentration much more fast after one big dose, and then I give smaller maintenance doses to maintain that. But anyway, this vacillation here is important. And again, if you ever miss a dose right here, notice how the concentration would go down. My trough now becomes much lower than it would be otherwise, right? Because again, I'm having more time to metabolize that drug. It's gone before I give the next dose. Okay. And again, in order to achieve the same average steady state concentration, I can achieve that multiple ways, right? So again, I can give a continuous infusion that achieves that plateau effect, that steady state level, and I can stay at that concentration, forever potentially, right? As long as I'm still infusing that drug into that patient at the same rate. Yes, sir.
The last slide. If you miss the dose and the trough goes down below, does it go back up to the same peak, or would it be a little
you'd actually find it probably be a little bit lower. It depends on how high that steady state level was to begin with. Yeah, so you may find it actually be a little bit lower, but potentially you could go up to that same Cmax. It just depends. Yep. So anyway, so there's several ways I can get the same thing here, because again, how easy is it to give a continuous infusion to a patient, say if they're on the outside, they're on the outpatient setting? Not super common, right? It's not very easy we can do that. Maybe if you had someone who had like a pump that was placed, they can continue to infuse drug over a long period of time, but it's exceedingly rare for the most part. So what I can do instead is give intermittent dosing. I can give doses over every so often in order to try to achieve the same thing. But when I'm not going to find that same nice plateau where I get the same concentration all the time, but I'll achieve the same average concentration, right, between those peaks and troughs. So again, if I were to give, say, a smaller amount of drug, say, every once in a while, say every 8 hours or so, you can see here I'm going to have a peak and it goes down, peak and it goes down, and then eventually I would get that same sort of average concentration there, right? However, I could give an even bigger dose, but give it at a longer interval. I can give it less frequently, and I can achieve the same concentration, average concentration, I should say, right? The bigger peaks and bigger troughs, but it still averages out the same as if I was giving it more frequently. So what do you think are some drawbacks to doing that method? Yeah, so for instance, if I have toxicity that occurs here, those peak levels might be too high for the patient. It might be developing some side effects associated with that. On the flip side, though, what could be some problems that got too low? Maybe it's less effective, right? So for instance, if I'm trying to kill off bacteria, but I need to keep the levels above this line here in order to kill off that bacteria, then all of a sudden now this is less effective, okay? So again, this is the reason why if you see something being given every 6 hours, you're like, man, that's kind of a bummer, I have to take it all the time. It could be related back to the fact that you don't want the concentration to be too high, you don't want them to be too low, okay? Again, about 4 to 5 steady state half-lives is going to take to actually get to the steady state concentration. Again, that can vary widely depending on the drug and how long that half-life actually is. Some drugs it's seconds, other drugs could be weeks to months potentially, right? All right. So looking at this clinical pharmacokinetics, this is where we're actually applying the principles of these kinetics we're learning about this semester to try to make sure we're having good, safe, and effective use of our medications, right? You're going to find that by prospectively trying to evaluate patients to see what type of dosing they should receive, how frequently they should receive a drug. You can try to bypass a lot of problems with the drug either not being very effective or it being toxic potentially, right? So this is why we're looking at things like the weight of the patient. We're looking at things like renal function and hepatic function to make sure that we're taking all these things into account to try to predict who's going to have a good response to these drugs here, right? Now, again, we can do this therapeutic drug monitoring. We're actually measure the level in the blood, but do we do that for every single drug? No, we're only going to do it for drugs that have what? We talked about drugs that have a very close dosing between their therapeutic effect and the toxic effect. Remember that narrow therapeutic index, right? Remember, we're actually dividing the ED50, or I'm sorry, the TD50 by the toxic dose 50 divided by the ED50. We want a very large interval there. That'd be great. But some drugs have a narrow therapeutic index where it's very small changes in dose can lead to toxicity, right? So we don't want that. So that's usually going to be the type of drugs we're going to do therapeutic drug monitoring on, either that or those that need to make sure they're achieving certain levels to be efficacious. And so antibiotics are going to be a big one. We'll talk about there a little bit later. So again, therapeutic drug monitoring is just using those serum concentrations. And again, the drug may not be active in the serum, but we're using that level as a surrogate of what should be out in the tissues that's actually active and doing whatever we're looking at. And so it's good to understand the merits and the limitations so that way you're not ordering drug levels for everybody. You want to be very judicious because again, are these tests free? No, they cost money, so you want to make sure you're doing it appropriately to make sure that anytime you're ordering a lab, you want to make sure you're actually, those values come back are actually going to do something for you, whether you make a decision to continue treatment or change, make some sort of change. It's important to make sure you are very judicious in your use of levels. Okay. So again, we used to use therapeutic drug monitoring, try to define kind of a therapeutic range, and you're going to find that with certain drugs, you're going to say, okay, we should be shooting between, say, 10 and 20 milligrams per ml, or mics per ml, whatever it happens to be. But you're going to find that, there are a lot of drugs, even if you have a level like that, it doesn't really correlate well to toxicity or effectiveness. So there's only going to be a select subset of drugs we're actually going to do this with, as we'll see. Again, usually the drugs that have a wider therapeutic index, they're considered to be much more safe. You would not really do therapeutic drug monitoring for those patients very frequently. Because again, at that point, if it's not effective, I can just drive up the dose, and I'm not really worried about toxicity being a problem. However, for something that has a very narrow therapeutic index, small changes there can be make the difference between having no side effects and having a ton of side effects. It could be potentially dangerous to the patient, right? Okay, and remember these slopes can be pretty steep depending on the type of drug you're dealing with and the effects they've seen in studies. Again, a sharper or a bigger, kind of slope to that curve, what do you think that means as far as when you make changes in dose? Small changes are going to make big differences, right? Again, if it was a more shallow sort of slope, you're going to find that you can make big changes in dose and not a lot of changes are going to occur with that, right? So again, that can be one thing they'll look at. Okay, and again, narrow therapeutic range just means that, remember what was happening when we get up to this this plateau point that's happening right here. Remember what was happening when it was getting saturated? Like all your receptors are getting saturated at that point. So again, you can, for certain drugs, as I start to drive up that dose to try to make sure that, getting enough people getting good response here, again, you're going to start to find that overlap. So this would be considered a drug with a narrow therapeutic index. As I get to closer and closer to something that will be effective for my patient, you're going to find that it's going to be more and more likely to develop toxicity there. Okay. And again, we're trying to look at this pharmacokinetic variability to determine what happens to our drug dose and then what kind of concentration we actually get at the site, right? So we're looking at changes in absorption, distribution, and metabolism, excretion, and that should be relating back to the effects we're going to see with that, right? So again, the pharmacokinetic variability is the biggest thing we're looking at, but some patients may have a little bit more of the pharmacodynamic variability. And what's the difference between those two as far as like pharmacokinetics versus dynamics? Remember that definition? So kinetics is what the body is doing to the drug, and the dynamics is what the drug is actually doing to the body there, right? So keep that variability in mind. Okay, and there's lots of things that could lead to variation in responses here. So for instance, drug interactions, right? So if I prevent a drug from being absorbed, it's not gonna have any effect, right? If I have drugs that have antagonistic actions, I'm taking an antihypertensive and then I'm taking a drug for weight loss that increases blood pressure, they can fight each other, right? These are all things that can lead to big differences. If I'm causing enzymes to be inhibited or induced, that can cause big effects on the kinetic side. So there's a lot of variability here, and that's why it's important when you're looking at drug interactions to kind of look at what the mechanism is to see what's happening, right? And when should you look up drug interactions for your patients? Really, you should get into a habit. Anytime you're really doing like a medication reconciliation, so maybe it's a new patient, you're going through their meds, look for interactions. Look for things that may be causing a problem for your patient. Maybe they're presenting with something that's actually a side effect. Unless you look at the interaction, you may not know it, right? Or anytime you do what? add a new med onto the patient, right? Especially when you're adding on new medications, you want to look for drug interactions, because otherwise, you can cause more problems than what you're trying to fix in the first place, right? Okay, so again, we've been doing this for several decades now. We realize that even though patients, even back in the 60s, half of adverse effects we were seeing were happening at therapeutic doses, right? So we realized that there was a need for certain drugs to try to be a little bit more specific to make sure the patient gets just the right amount of drug, not too little, not too much, in order to make sure they're going to have good effects from the medication. Okay. Anyway, we've been doing a lot of investigation. I'm not going to bore you with the history too much about this. But just know that there's a point where we decided for certain drugs, we could say that, okay, this surrogate level in the blood is a pretty good predictor of what's in the tissue, and that can help us to predict the response we're going to see from these medications. Okay, so important considerations. This does not apply to every single drug. There's going to be a certain list of drugs you'll do this with. Again, I'm not going to have you memorize a list necessarily, but I will, again, concepts here are the big things to note. For certain drugs, you don't have to measure the blood level to actually determine whether it's being effective or not. So for instance, if I'm giving you an antihypertensive, what can I measure to see how well it's working? I can just measure your blood pressure, right? That's pretty good. If I was giving you a drug for your diabetes, what can I measure? Your blood sugar, right? So again, there are indirect measurements, or these direct measures of the patient that I can use to determine how well my drug is specifically working, right? Or potentially toxicity. So if I was giving you a med to lower your blood sugar, what would be evidence of toxicity? Hypoglycemia, right? So then I can measure that blood sugar, and if it's 30, then I know, okay, maybe I overdid it a little bit. Maybe I should reduce my dose to some degree, right? Some other drugs will have other measures. So for instance, warfarin is a drug we know that inhibits production of clotting factors in the liver, certain clotting factors. We look at PTINR, right? So I don't need to look at a warfarin level, but I can look at the PTINR to determine how thin the blood is to make sure that my patient's not at too big a risk for bleeding, but they're also not likely to develop a stroke from, say, a clot due to AFib, right? So again, sometimes we're going to look at other measurements that are not related specifically to the drug level itself. Okay, so again, we should make a couple of assumptions here when we're doing therapeutic drug monitoring. We're saying that, there is some opportunity by measuring these drug concentrations to try to adjust, to change the dose, right? So again, we know that based on the pharmacokinetic variability in our patient, we can make those changes to the drug dose to try to overcome that, essentially, right? So we need to make that assumption. We need to know that drug concentration is a better predictor of response than the dose itself. So for instance, again, if I'm measuring blood pressure for an antihypertensive, that's a better measurement than actually getting a level of, captopril or whatever antihypertensive we're giving, right? And then there should be a good relationship between drug concentration and the actual pharmacologic response. So for instance, if I give more drug, I should get more response. If I give less drug, I should get lesser response. Okay. All right, so looking at an actual drug exposure, there's going to be certain things that we can change and certain things that we have no ability to change. So for instance, bioavailability, we can't really do anything about that. I can't change how well a drug gets absorbed. I could potentially change the route I'm giving it. Maybe instead of PO, I give it IV. That way I can ensure bioavailability. That's one thing potentially. And then clearance as well, right? I can't change how well a patient's kidneys function. In rare instances, maybe I put them on dialysis to clear a drug, but that's usually going to be pretty rare for the most part. So I can't really change those, but the big thing I can change, and you guys will be able to change, is going to be drug dose, and then how frequently you're going to be giving it, okay? And so you notice here, looking at the exposure, and you can kind of equate this back to the concentration, this being in the numerator, if I give a bigger dose, what is that going to do to my concentration? Going to go up, so more drug exposure, higher concentration. If I give the interval, that increases. That goes, say, from giving something every 8 hours, every 12 hours, that should go. Drug concentration is down, right? So again, because I'm going to have more time for drug to be metabolized, those levels have more time to go down before that next dose is administered there, right? So again, looking at therapeutic ranges, whenever I put like a level on a test or something like that, I always put like a therapeutic range associated with it, or like a reference range. Keep in mind those are not absolute, right? We talk about this in biostats or EpiBio coming up next semester. You're going to find that the normal range really only covers a majority of people, but people fall outside of that all the time, right? Everyone's a little bit different. You can have somebody who is too low a level of a drug, but it's working perfectly for them. Maybe their seizures are controlled, maybe they have no issues. You don't necessarily need to chase that number, right? Treat the patient, not the numbers, is basically the ultimate message here. But with this therapeutic ranges, we can say that most people should respond to the drug without having too much toxicity at this range, and that's how we come up with them essentially, right? So again, this is going to be the range where most likely to get a good response, and we're less likely to see a lot of toxicity there. Okay, but again, if a patient comes back with a wacky number and they're doing totally fine, I don't necessarily need to change that, right? If it's a little too high, but they're totally fine, no side effects, then leave it alone. Okay. Okay. Also, consider where they're getting these ranges from. They usually do these studies. Usually they're not in huge populations. So you have to kind of look back and see like, well, does this actually apply to my patient? You know, if they did this study back in the 50s to get this range that was meant for, you know, they only did males in the military, that may not be, all that be reliable if I'm dealing with female patients, you know, at all, right? So again, you have to look at these study populations to see how applicable that information can be. That's another concept we'll go over in EpiBio later on. And sometimes it can be pretty hard to tell where these ranges actually come from. In fact, you know, some of these studies were done back like in the 40s and the 50s, and if you actually go back and try to find the papers, like it can be exceedingly difficult. I actually remember one of my professors in pharmacy school, you know, I went to UF, and he was talking about how, you know, these ranges, you know, by changing the range, you can change, you know, what is considered normal and not normal. And he was, you know, he's trying to rag on FSU a little bit, and he's like, yeah, it's interesting. FSU never has any, you know, football players pop positive for THC. Also, their range for what actually is a positive is a lot higher than what UF's is, but you know, whatever. So again, ranges can change. Everywhere you work is going to have different ranges for every lab, essentially. So kind of get familiar with those because that can be important discerning if this is normal or not. Okay. Usually we're going to be shooting for a specific target concentration. So I usually try to shoot for middle of the road. If my range, say for instance, is 10 to 20, I'll shoot for 15 essentially, right? So by shooting for that concentration, I can try to calculate what actual dose I'm going to give to try to achieve that, okay? And then usually for our patients, we're going to assume that they're an average member of the population, unless they have something, you know, obvious that I need to actually account for. So for instance, you know, if I'm dealing with an otherwise healthy patient coming in for an infection, I'm going to treat them like every other patient that's out there. Because I'm using studies that kind of took averages of these populations, and now I'm applying that to an individual patient here. Now, obviously, that's something huge going on, like their kidneys don't function or whatever. I can take that into account as well. But this helps us to use these pharmacokinetic parameters to try to establish what is going to be appropriate for my patient, right? And again, if we're dealing with looking at these concentrations, you know, again, consider how long does it take to get to steady state? 4 to 5 half-lives, right? So again, it takes 4 to 5 half-lives. If I measure concentration before that time period has occurred, what is it going to look like? Too high, too low? It's going to be too low. If I check it too soon, and this is one of the biggest problems I run into. Nurses, if you know, there's an order on the chart to get a level at a certain time, they'll end up drawing it, say, you know, a dose or too early, and then they'll say, okay, well, you know, the provider gets it back and say, oh, the level's too low. Obviously, you need to increase the dose. And they'll say, wait a second, look at the timing. Had you waited until steady state, it probably would have been higher. They recheck it, and the level's fine. That's one of the big things to note is that you want to make sure you're at steady state anytime you're checking these levels. Okay. And then we'll look at some different scenarios. I'm going to let you guys go now. Any questions before I let you go? All right, we'll see you guys next time then.